Hello, welcome to Lesson 1 on Pharmacology Review. To begin, I wanted to give a primer about the difference between pharmacokinetics and pharmacodynamics. Pharmacokinetics is essentially the study of what the body does to the drug, versus the pharmacodynamics is the study of what the drug does to the body. In older adults, why does induction dose of IV and inhaled induction agents decrease? Because of pharmacokinetics. Decrease. Because the pharmacokinetics decrease. What are the reasons for pharmacokinetics decreasing? They decrease due to age-related decrease in volume of distribution. There's decrease in plasma protein binding and decrease in drug metabolism, renal mostly, along with and also pharmacodynamics. So the reason why pharmacokinetics decrease is because they decrease in age-related decrease in volume of distribution, decrease in plasma protein binding, decrease in drug metabolism, mostly renal, and pharmacodynamics. How does volume of distribution decrease with age? There's lower total body of water and muscle mass. There's lower total body of water and muscle mass. What drugs do not get affected by pharmacodynamics? I hope you're saying muscle relaxant, also known as neuromuscular blocking agents. Muscle relaxant. What is the official definition for pharmacodynamics? Well, I hope you're saying sensitivity in central nervous system to a hypnotic agent. Sensitivity in central nervous system to a hypnotic agent. In older adults, which drug pharmacodynamic sensitivity remain unchanged? Well, I hope you're saying etomidate and thiopental. Etomidate and thiopental remain unchanged with their pharmacodynamics as it relates to older adults. In older adults, which drug pharmacodynamic sensitivity increases? Well, I hope you're saying propofol, opioids, and inhaled anesthetics. Propofol, opioid, and inhaled anesthetic. What happens with pharmacokinetics in older adults? They decrease in hepatic metabolism and renal function, prolonging the duration of action and decrease in drug clearance. Once again, for pharmacokinetics, there's a decrease in hepatic metabolism and renal function in older adults, prolonging the duration of action and decrease in drug clearance. In older adults, what accounts for age-related changes in pharmacodynamics and inhaled anesthetic decrease of MAC of 6%? There are changes in ion channels, synaptic activity, and receptor sensitivity. Changes in ion channels, synaptic activity, and receptor sensitivity. Does age affect muscle relaxant, such as non-depolarizing, depolarizing agent pharmacodynamics? No. Age does not affect pharmacodynamics, but does affect pharmacokinetics for muscle relaxants. The direction of action of drug depends on what? Well, I hope you're saying hepatic and renal metabolism. Hepatic and renal metabolism. Why is pancuronium clearance decreased in older adults? Because of its dependence on renal excretion. Because of its dependence on renal excretion. Pancuronium is renally excreted. Cis-atracurium is degraded in what fashion? Well, I hope you're saying Hoffman degradation. Hoffman degradation. Is Hoffman degradation affected by age? No, it is not affected by age. Hoffman degradation is not affected by age. Now, this brief section will be about meperidine. Why does meperidine cause tachycardia in adults? Well, I hope you're saying because it's similar structure to atropine. Similar structure to atropine. Of note, meperidine also has weak local anesthetic properties. Meperidine also has weak local anesthetic properties. High doses of meperidine cause what hemodynamic changes? Well, I hope you're saying hypotension and tachycardia. Hypotension and tachycardia. What is the mechanism via which it causes hypotension and tachycardia? Well, I hope you're saying histamine release. What other drug besides meperidine acts similar to its mechanism of action through histamine release? Well, I hope you're saying morphine. Morphine. In high concentrations, meperidine does what to cardiac contractility? Well, I hope you're saying it decreases it. It decreases it. Can it be reversed with naloxone? The decrease in cardiac contractility. No, it is resistant to naloxone. It is resistant to naloxone. What is the mechanism of hypotension of meperidine? Well, we just went over that. I hope you're saying histamine release. Histamine release. Opioids are routinely given to prevent what? They're given to prevent tachycardia and reduce myocardial oxygen demand. They reduce myocardial oxygen demand. Rapid fire questions. What happens to circulating albumin in older adults? It decreases. It decreases. What happens to alpha acid glycoprotein? Well, I hope you're saying that alpha acid glycoprotein increases. What happens to hepatic metabolism in older adults? It decreases. Hepatic metabolism decreases in older adults. What mechanism of action of metoclopramide? It is a dopamine antagonist. Dopamine antagonist. Does metoclopramide have an effect on gastric acidity? No, it does not. At what dose does metoclopramide not affect reducing nausea and vomiting? At 10 milligrams or below. It doesn't affect reducing nausea or vomiting. How is etomidate metabolized? Etomidate is metabolized via hepatic ester hydrolysis to an inactive metabolite that is renally excreted. Etomidate is metabolized through hepatic ester hydrolysis to an inactive metabolite that is renally excreted. How are hypnotic effects terminated of etomidate? There's redistribution and decreased clearance. There's redistribution and decreased clearance. What is cerebral blood flow of etomidate? What does it cause? Well, I hope you're saying that it reduces it. It reduces it. What effect of etomidate on cerebral metabolic rate? It reduces it. It reduces cerebral metabolic rate. Why is intracranial pressure decreased when using etomidate? The cerebral pressure is decreased because of cerebral blood flow and cerebral metabolic rate decrease. There's a decrease in cerebral blood flow and cerebral metabolic rate, resulting in intracranial pressure decrease. What happens to cerebral perfusion pressure with etomidate? It is unchanged or increase. It is unchanged or increase. Why is cerebral perfusion pressure with etomidate preserved? Well, I hope you're saying because there's maintenance of mean arterial pressure. There's maintenance of mean arterial pressure. And while we're here, what is the equation for cerebral perfusion pressure? Well, I hope you're saying cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. Cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. What is a common neurological side effect of etomidate? Well, I hope you're saying activation of epileptogenic foci on EEG causing seizure activity. There is activation of epileptogenic foci on EEG causing seizure activity. Can a BIS monitor be used reliably with etomidate? Yes, you can use a BIS monitor reliably with etomidate. Does etomidate affect on ventilation compared to propofol and barbiturates? Less. Does etomidate affect on ventilation compared to propofol and barbiturates less? What can it cause on induction? It can cause transient apnea. It can cause transient apnea. Does etomidate can etomidate be used in an unstable patient? Yes. It has preserved heart contractility, little effect on venous or arterial tone. Once again, it preserves heart contractility and has little effect on venous or arterial tone. What enzyme does etomidate inhibit? Well, I hope you're saying 11-beta hydroxylase, leading to decreased synthesis of cortisone and aldosterone. Etomidate inhibits 11-beta hydroxylase, leading to decreased synthesis of cortisol and aldosterone. Does etomidate require a reduction in renal or hepatic insufficiency? No, etomidate does not require a reduction in renal or hepatic insufficiency. What are etomidate side effects? Well, I hope you're saying myoclonus, adrenal suppression, pain and injection, and post-operative nausea and vomiting. Once again, the 4 side effects are myoclonus, adrenal suppression, pain and injection, and post-operative nausea and vomiting. What is etomidate, ketamine, and propofol action on pulmonary vascular tone? Once again, the 3 etomidate, ketamine, and propofol action on pulmonary vascular tone. They equally attenuate bronchoconstrictive responses to acetylcholine and bradykinin. They attenuate bronchoconstrictive responses to acetylcholine and bradykinin. When is a higher dose of etomidate required? Well, I hope you're saying hemorrhagic trauma. Hemorrhagic trauma. What happens to airway reflexes with ketamine? There's laryngeal reflexes are preserved. Laryngeal reflexes are preserved. What happens to airway reflexes with ketamine? Laryngeal reflexes are preserved. What happens to respiratory drive with ketamine? Well, I hope you're saying it is unchanged. Respiratory drive remains unchanged with ketamine. What is analgesic effect with ketamine? Well, I hope you're saying that it is increased. There is increased analgesic effect. What happens to sympathetic tone of ketamine when ketamine is used? It is increased. There is an increase in myocardial stimulation. The depression is never really clinically significant. So sympathetic tone of ketamine is increased, and then there is an increase in myocardial stimulation. Which induction drug has no effect on seizure duration? Well, I hope you're saying methotrexate. Methotrexate. Methotrexate has no effect on seizure duration. Which induction drug increases seizure duration? Well, I hope you're saying ketamine and etomidate. They increase seizure duration. Ketamine and etomidate increase seizure duration. Which induction drug decreases seizure duration? Well, I hope you're saying propofol. Propofol. Which adjunct drug increases duration of seizure? Well, I hope you're saying remifentanil can increase or have no change on seizure duration. Remifentanil can have increase or no change in seizure duration as a adjunct drug. What adjunct drug can decrease seizure duration? Well, I hope you're saying lidocaine or midazolam. Lidocaine or midazolam are adjunct drugs that can decrease seizure duration. Which drugs decrease cerebral blood flow and cerebral metabolic rate? Well, I hope you're saying a total of 6 of them. They're fentanyl, propofol, etomidate, dexmedetomidate, sulfentanyl, and morphine. Once again, the drugs that decrease cerebral blood flow and cerebral metabolic rate are fentanyl, propofol, etomidate, dexmedetomidate, sulfentanyl, and morphine. Midazolam decreases cerebral blood flow but has no change on cerebral metabolic rate. Once again, midazolam decreases cerebral blood flow but has no change on cerebral metabolic rate. Which drugs cause increase in cerebral blood flow? Well, I hope you're saying ketamine, all inhalational anesthetics, and nitrous oxide. Ketamine, all inhalational anesthetics, and nitrous oxide cause increase in cerebral blood flow. What is inhalational agent effect on cerebral metabolic rate? Well, I hope you're saying decrease in cerebral metabolic rate. Decrease in cerebral metabolic rate. What drugs increase cerebral metabolic rate? Which drugs increase cerebral metabolic rate? Well, I hope you're saying ketamine and nitrous oxide. Ketamine and nitrous oxide. What drugs are metabolized by butyrylcholinesterase, also known as pseudocholinesterase? Well, I hope you're saying mivacurium and succinylcholine. Mivacurium and succinylcholine. What drug should be avoided in pregnancy? Well, I hope you're saying benzodiazepine. Benzodiazepine. What are safe induction agents in pregnancy? Well, I hope you're saying etomidate, propofol, and rocuronium. Etomidate, propofol, and rocuronium. If you increase neural activity in the brain, that means that you will increase cerebral metabolic rate and increase in cerebral blood flow. If you increase neural activity in the brain, you will most likely increase cerebral metabolic rate and increase in cerebral blood flow. So a 14-year-old receives succinylcholine during induction at the end of the procedure, and essentially 90 minutes later, patient is still very weak and apneic. What happened to the train of 4? Keep in mind the patient was received succinylcholine. Well, I hope you're saying that the train of 4 fade is likely on the quantitative neuromonitoring. So what happened here? Well, the patient has heterozygous butyrylcholinesterase deficiency. On heterozygous, there is a 15-minute prolongation, and homozygous typically have 2-hour prolongation. How many alleles are there for butyrylcholinesterase? Well, I hope you're saying there's 4. There is U for usual, A for atypical, S for silent, and F for fluoride. U for usual, A for atypical, S for silent, and F for fluoride. Which pseudocholinesterase allele is inhibited by dibucane? Well, I hope you're saying U allele. U allele is inhibited by dibucane. Which pseudocholinesterase allele is resistant to dibucane? It's the A, atypical allele. What phase does succinylcholine normally block? I hope you're saying phase 1 block. It is often preceded by muscle fasciculations. Phase 1 is the block for succinylcholine and often preceded by muscle fasciculations. What type of block is expected with pseudocholinesterase deficiency with succinylcholine? Well, I hope you're saying it resembles a phase 2 block, termed train of 4 fade, also known as tetanic fade, or post-tetanic potentiation. Once again, the block that's expected in pseudocholinesterase deficiency with succinylcholine resembles a phase 2 block, different from its phase 1 block, termed train of 4 fade, or also known as tetanic fade, or also known as post-tetanic potentiation. What is expected when succinylcholine is given in high doses, like 5 milligrams a kilogram? Once again, phase 2 block with train of 4 fade, very similar to pseudocholinesterase deficiency. What is desensitization block when continued presence of an agonist causes acetylcholine receptor to become insensitive to binding of agonist? Essentially, a desensitization block is when continued presence of an agonist causes an acetylcholine receptor to become insensitive to a binding of an agonist. By how much dose serum potassium increase with succinylcholine? Well, I hope you're saying half a milli equivalent per liter, even with severe renal insufficiency. So the serum potassium, if you use succinylcholine, goes up by 0.5, even with severe renal insufficiency. What pathologies would you expect severe hyperkalemia with succinylcholine? Well, there's quite a few. I hope you're saying spinal cord injuries, neuromuscular disorders such as amyotrophic lateral sclerosis, multiple sclerosis, Friedreich ataxia, and for Guillain-Barré. There's also strokes, major traumas, extensive burns, prolonged mobility. So, what pathologies cause severe hyperkalemia? I hope you're saying spinal cord injuries, neuromuscular disorders such as amyotrophic lateral sclerosis, multiple sclerosis, Friedreich ataxia, Guillain-Barré, also stroke, major trauma, extensive burns, and prolonged mobility. What is the mechanism of hyperkalemia with succinylcholine and these injuries? I hope you're saying upregulation of extrajunctional receptors. Upregulation of extrajunctional receptors in these pathologies is the mechanism for how there is increased potassium. Why do infants have higher initial uptake of volatile anesthetic? Well, I hope you're saying it's due to increased minute ventilation to a functional residual capacity ratio. Infants have higher initial uptake of volatile anesthetic because there is increase in minute ventilation to functional residual capacity ratio. Another way to think about it is FRC adults have less air to dilute air in. However, minute ventilation places more anesthetic into lungs where it can be taken up. Is MAC requirements higher in infants and it peaks at 6 months of age? MAC requirements are higher in infants and peak around 6 months of age. What factors increase uptake of volatile anesthetics in infants? Well, I hope you're saying increased cardiac output and increased minute ventilation. Increased cardiac output and increased minute ventilation increase uptake of volatile anesthetic in infants. What effect do volatile anesthetics have on mucus clearance? Well, I hope you're saying there's decrease in mucus clearance. What effect do volatile anesthetics have on respiratory rate? Well, I hope you're saying it has decreased respiratory rate. What effect do volatile anesthetics have on tidal volume? They decrease the tidal volume. What effect do volatile anesthetics have on response to hypercapnia and hypoxia drive? They depress central response to hypercapnia and hypoxia. Once again, volatile anesthetics depress central response to hypercapnia and hypoxia. What type of injury can all volatile anesthetics cause? Well, I hope you're saying they can cause exacerbation of acute lung injury with their pro-inflammatory actions. They can cause acute exacerbation of the lung with their pro-inflammatory actions. So the next little segment is about non-depolarizing neuromuscular blockade effects. Potentiation means there's increase in their effectiveness, and attenuation means there's a decrease in their effectiveness on the duration. What effect does combination of two of the same class of non-depolarizing neuromuscular blocking agents have from the same class? Well, I hope you're saying it is additive. There's an additive effect if they're put together. What effect does combination of two different class of non-depolarizing neuromuscular blocking agents have from the same class? Well, I hope you're saying synergistic. Synergistic. So once again, if you're using two of the same class, there's an additive. If you're using two of essentially different class, there is a synergistic effect. What effect do inhaled anesthetics have on duration of blockage? They potentiate it. And in what order do inhaled anesthetics have increased duration of blockage? Well, the greatest one comes with desflurane, followed by sevoflurane, followed by isoflurane, followed by nitrous oxide. The potentiation of the blockade is greatest with desflurane, followed by sevoflurane, followed by isoflurane, followed by nitrous oxide. What effect do antibiotics have on neuromuscular blockade? Well, I hope you're saying potentiation. They potentiate neuromuscular blockade. What are the specific types of antibiotics that do potentiate neuromuscular blockade? Well, I hope you're saying tetracyclines, aminoglycosides, polymyxins, and clindamycin. Once again, they're tetracyclines, aminoglycosides, polymyxins, and clindamycin. What effect does anticonvulsants such as phenytoin and carbamazepine have on neuromuscular blockers chronically and acutely? Once again, what effect do anticonvulsants such as phenytoin and carbamazepines have on neuromuscular blockade chronically and acutely? Anticonvulsants have potentiation acutely and chronic attenuation. This is very important to understand. Anticonvulsants have potentiation acutely, and chronically there's attenuations from drugs like phenytoin and carbamazepine on neuromuscular blockade. What effect does lithium have on neuromuscular blockade? Well, I hope you're saying potentiation. Potentiation. What effect do local anesthetics have on neuromuscular blockade? They potentiate neuromuscular blockade. They potentiate the neuromuscular blockade. So, myasthenia gravis patient, what effects does pyridostigmine have on succinylcholine? Pyridostigmine potentiates effect on succinylcholine. How does pyridostigmine potentiate succinylcholine? It inhibits activity of butyrylcholinesterase, also known as plasma cholinesterase. It inhibits the activity of butyrylcholinesterase. What is the mechanism of action of pyridostigmine? Well, pyridostigmine inhibits acetylcholinesterase, leading to increase in acetylcholine in neuromuscular junction, leading to higher chance of a successful signal transmission. So you're essentially having more acetylcholine by inhibiting acetylcholinesterase. Continuing on. Should aspirin be continued before coronary artery bypass graft? Yes, aspirin should be continued before coronary artery bypass graft. Can patients take aspirin undergoing minor surgery? Yes, they can. Blood gas coefficients. The higher the number, the more soluble it is in blood, and the higher blood gas coefficient means the longer it takes to induce a patient. This is very important to understand. For blood gas coefficients for volatile anesthetics, the higher the number, the more soluble it is in blood, and the higher blood gas takes in order to induce a patient. Higher blood gas coefficient means you need more anesthetic to be dissolved in blood. Higher blood gas coefficient means you need more anesthetic to be dissolved in blood for it to take effect. The speed of onset is faster with smaller blood gas coefficient. The speed of onset of action is faster with smaller blood gas coefficient. Why does nitrous oxide have faster onset than desflurane despite having larger blood gas coefficient? Well, nitrous oxide has a faster onset than desflurane due to concentration effect. A way to think about it is that the body preferentially takes up more nitrous oxide than any other inhalational agent. It preferentially takes up nitrous oxide more than any other inhalational agent, and you can think of that as concentration effect. What are the blood gas coefficients? What is blood gas coefficient for desflurane? I hope you're saying 0.42. 0.42. What is blood gas coefficient for nitrous oxide? I hope you're saying 0.46. 0.46. What is the blood gas coefficient for sevoflurane? I hope you're saying 0.65. 0.65. What is the blood gas coefficient for isoflurane? 1.46. 1.46. Which anesthetic has lowest vapor pressure at 20 degrees Celsius? I hope you're saying desflurane. Desflurane has the lowest vapor pressure at 20 degrees Celsius. And briefly, to talk about the vapor pressures for boiling points and vapor pressures at 20 degrees Celsius for inhalation agents. What is the vapor pressure and boiling point for desflurane? Boiling point for desflurane is 24 degrees Celsius and a vapor pressure of 669. 669 is the vapor pressure for desflurane. Isoflurane. Its boiling point is at 49 degrees Celsius, and its vapor pressure is 238. 238 is the vapor pressure of isoflurane, and the boiling point of 49 degrees Celsius. Sevoflurane. What is its boiling point? Well, I hope you're saying 59 degrees Celsius. 59 degrees Celsius. Its vapor pressure is 157 millimeters of mercury. 157 millimeters of mercury is the vapor pressure for sevoflurane. What is the boiling point for nitrous oxide? Well, I hope you're saying negative 88 degrees Celsius. Negative 88 degrees Celsius. With a vapor pressure of 38,770. 38,770 is the vapor pressure of nitrous oxide. Which inhaled anesthetic undergoes most extensive metabolism? Well, I hope you're saying sevoflurane. Sevoflurane undergoes the most extensive metabolism. Which is the second most extensive metabolism? Volatile anesthetic. Well, I hope you're saying isoflurane. Isoflurane. Which inhaled anesthetic is the third most extensive metabolism? Well, I hope you're saying desflurane. Desflurane. What is the byproduct of sevoflurane? Increased serum fluoride concentration. Sevoflurane byproduct is increased serum fluoride concentration. So let's say a patient is induced by enflurane and presents with elevated dehydration, elevated creatinine, BUN. He has polyuria, hypernatremia, and elevated serum osmolarity. Enflurane gives nephrotoxicity that does not respond to vasopressin. It causes nephrotoxicity that does not respond to vasopressin. What effect do inhaled anesthetics have on respiratory drive? Well, I hope you're saying dose-dependent decrease. Inhaled anesthetics have dose-dependent decrease on respiratory drive. Does nitrous oxide have decrease on respiratory drive? No, it does not. Nitrous oxide does not have decrease on respiratory drive. What effect do opioids have on respiratory system? They produce a dose-dependent depression of ventilatory response to carbon dioxide and decreased respiratory rate. Once again, opioids produce a dose-dependent depression of ventilatory response to carbon dioxide and decreased respiratory rate. What is tizanidine prescribed for? Tizanidine is prescribed for musculoskeletal pain. Musculoskeletal pain. What is tizanidine mechanism of action? Well, I hope you're saying alpha-2 agonist. Alpha-2 agonist. Bosentan, what is it prescribed for? Pulmonary hypertension causing vasodilation. What is the mechanism of action of bosentan? It is endothelin receptor blockade. Endothelin receptor blockade. Terbutaline, is it a tachylytic? And what does it cause? Terbutaline causes vasodilation. It's a tachylytic that causes vasodilation. Dilation. What is the mechanism of action of terbutaline? It is a beta-2 agonist. Beta-2 agonist. Yohimbine. What is the mechanism of action of yohimbine? Alpha-2 antagonist. Alpha-2 antagonist. What is yohimbine used for? Sexual dysfunction. Sexual dysfunction. What is albuterol's mechanism of action? Beta-2 agonist. Beta-2 agonist. Ridodrine. What is its mechanism of action? I hope you're saying beta-2 agonist. Beta-2 agonist. Glucagon increase in cyclic AMP has what effect on ionotropy and chronotropy? It increases ionotropy and increases chronotropy via non-adrenergic effect. It increases ionotropy and increases chronotropy via non-adrenergic effect. What drugs are not dependent on CYP450 system and can be safely administered in HIV heart therapy? Well, I hope you're thinking of 5 of these. They are desflurane, etomidate, remifentanil, cisatracurium, and atracurium. The drugs that are not CYP450 system dependent are desflurane, etomidate, remifentanil, cisatracurium, and atracurium. How are benzodiazepines metabolized? CYP450 system. CYP450 system. What drugs induce CYP450 system? Barbiturates. Barbiturates induce CYP450 system. What is steroids' anti-inflammatory mechanism of action? They antagonize nuclear receptor subfamily 3, group C, member 1 receptor. They antagonize receptor subfamily 3, group C, member 1 receptor, and inhibit prostaglandin synthesis in arachidonic pathway. They also inhibit prostaglandin synthesis in arachidonic pathway. What is the mechanism of action of atropine? It's a muscarinic antagonist. Muscarinic antagonist. What is the effect of muscarinic antagonism? Inhibition of parasympathetic system. I hope you're thinking inhibition of parasympathetic system. Which muscarinic antagonist has the greatest CNS depression? Well, I hope you're saying scopolamine. Scopolamine has the greatest depression of CNS system. Which muscarinic antagonist has the greatest increase in heart rate? I hope you're saying atropine. Atropine has the greatest increase in the heart rate. Both scopolamine and atropine are tertiary amines, while glycopyrrolate is a quaternary amine. Why use epidural drugs over systemic opioids? Why use epidural drugs over systemic opioids? Well, because epidurals allow for rapid return of gastrointestinal function. They improve postoperative pain control, improve cardiovascular outcomes, reduce thrombotic events, and improve participation in post-surgical rehabilitation. Once again, epidurals compared to systemic opioid therapy improve GI function, post-operative pain control, cardiovascular outcomes, reduce thrombotic events, and improve participation in post-surgical rehabilitation. What is nicotinic effect on post-operative nausea and vomiting? It is reduced. What is the mechanism of action of nicotine reducing post-operative nausea and vomiting? It decreases dopaminergic circuits in chemotactic trigger zone. Once again, it reduces dopaminergic circuits in chemotactic trigger zones. Where are these chemotactic trigger zones located anatomically? I hope you're saying medulla. They're located in the medulla. Why does isoflurane have the lowest rate of rise of FA to FI? Why does isoflurane have the lowest rate of rise of FA to FI? Because it has highest blood gas solubility coefficient. Blood gas solubility coefficient. Which opioid has context-sensitive half-time independent of infusion duration? Which opioid has the context-sensitive half-time independent of infusion duration? Well, I hope you're thinking remifentanil. Remifentanil. Anaphylactic reaction is what type of immune response? Well, I hope you're saying it is IgE immune reaction. IgE immune reaction is the anaphylactic reaction. What type of an immune response is contact dermatitis? Well, I hope you're saying it is T-cell mediated. T-cell mediated. What type of a graph for the first order kinetics? I hope you're thinking of a straight line. What type of a graph present with a curved line? I hope you're thinking first order kinetics. First order kinetics. Second and third order do not exist. How does digoxin toxicity manifest? There are GI, neurological, and cardiac side effects. There are GI, neurological, and cardiac side effects. What can cause digoxin toxicity? Well, I hope you're thinking hypothyroidism, renal insufficiency, and electrolyte abnormalities, specifically hypomagnesemia, hypokalemia, and hypercalcemia. Once again, Digoxin toxicity can be caused by hypothyroidism, renal insufficiency, hypomagnesemia, hypokalemia, and hypercalcemia. Electrocardiograms with digoxin toxicity typically show ST segment depression, also known as scooping. It literally looks like ST depression. How are local anesthetics such as bupivacaine, ropivacaine, and lidocaine metabolized? They're metabolized hepatically. What prolongs local anesthetic metabolism? Well, I hope you're saying all the things that cause liver issues. They're the things that cause liver issues. In the instance of neonatal period, it is immature liver. End-stage hepatic disease causes issues with anesthetic metabolism. Congestive heart failure due to decreased blood flow to the liver. So the three things that prolong local anesthetic metabolism are neonatal period due to immature liver, end-stage liver disease, and congestive heart failure due to decreased blood flow to the liver. What is an absolute contraindication of local anesthetic injection? The absolute contraindication is simultaneous injection of liposomal bupivacaine with another local anesthetic. It should not be injected simultaneously. Something acceptable would be like injecting lidocaine 20 minutes before liposomal bupivacaine. What MAP goal should surgeries that require controlled hypertension be? Well, I hope you're saying 50 to 60 MAP. 50 to 60 MAP. What are the medications used to control hypertension? Well, for anesthetics, I hope you're saying volatile anesthetics. For contralateral hypertension, it is volatile anesthetics. For antiarrhythmic, for control hypertension, you can use adenosine. For controlled hypertension, for the opioid, I hope you're saying remifentanil. For controlled hypertension, for vasodilators, I hope you're saying nitroprusside, nitroglycerin, phenoldopam, and clonidine. Once again, for vasodilators for controlled hypertension, you can use nitroprusside, nitroglycerin, phenoldopam, and clonidine. What type of antihypertensive can be used in controlled hypertension? Well, I hope you're saying calcium channel blockers, beta blockers, and ACE inhibitors. Calcium channel blockers, beta blockers, and ACE inhibitors are antihypertensives used in controlled hypertension. What type of prostaglandins E1 analogs can be used in controlled hypertension? Well, I hope you're saying alprostadil. What is the mechanism of action of phenoldopam? It is a D1 dopamine receptor. It has rapid vasodilation. Once again, mechanism of action for phenoldopam is D1 dopamine receptor agonist, and it causes rapid vasodilation. What is a contraindication to controlled hypertension? Well, I hope you're saying elevated intracranial pressure. Elevated intracranial pressure is a contraindication to controlled hypertension. What surgeries require controlled hypertension? Well, I hope you're saying surgeries involving significant blood loss, cerebral aneurysm repair, maxillofacial or sinus surgery, multi-level spine surgery, total hip arthroplasty, radical neck dissection, and radical cystectomy. Controlled hypertension surgeries are surgeries involving significant blood loss, cerebral aneurysm repair, maxillofacial or sinus repair, multi-level spine surgery, total hip arthroplasty, radical neck dissection, and radical cystectomy. What is a contraindication to controlled hypotension? We've gone over that. It's elevated intracranial pressure. What is mechanism of action of acetazolamide? It is inhibition of carbonic anhydrase, which prevents resorption of bicarbonate, sodium, and chlorine. Mechanism of action of acetazolamide is inhibition of carbonic anhydrase, preventing resorption of bicarbonate, sodium, and chlorine. What are the lab findings with the chronic administration of acetazolamide? Again, chronic administration of acetazolamide. Well, I hope you're saying metabolic acidosis and hypokalemia, while having normal calcium and normal magnesium. Once again, chronic administration of acetazolamide causes metabolic acidosis and hypokalemia with normal calcium and normal magnesium.